A very good afternoon, everyone. It is my pleasure to welcome you all to the 11th Pediatric TB Eco Clinic in collaboration with Regional Pediatric Center of Excellence for Tuberculosis. The clinic is dedicated to challenging cases of pediatric tuberculosis. Tuberculosis remains one of the most pressing global health issues in children and is associated with complexities and diagnosing and treating TB in pediatric patients. On behalf of NITRD, I extend my warm greetings to the directors and team from NIIT, NTI, STOs, directors of STDCs, faculty of medical colleges, district TB officers, medical officers, TB pediatricians, and everyone present here today. Without any further delay, let me introduce the faculty from NITRD. I'm Dr. Dhulika Dhingra, Specialist Pediatrics at NITRD, and I will be moderating today's session. To my right is Dr. Sangeeta Sharma, Chief in Charge, National Center of Excellence and ex-Director, NITRD, and Dr. Alok would be joining us soon. I would now request our director, Dr. Manpreet Bhalla ma'am, to give her inaugural address.
Thank you, Dr. Dhulika and Dr. Sangeeta Sharma. So, good afternoon. I welcome you all for this pediatric TB Eco Clinic. As we all know that we are holding this TB Eco Clinics regularly, and these are held in order to facilitate all the centers with a panel of experts. So, as we all know that pediatric TB is very challenging, and so all challenging cases are discussed regularly. And so I think today's also session will be on a challenging case, and we look forward. And if you have any doubts, this is the best platform for you to clarify your doubts. So I welcome you for this session, and I think we.
Thank you, ma'am. I would now request Dr. Sangeeta Sharma for her inaugural remarks. Over to you, ma'am.
Thank you, Dhulika. I mean, it's so heartening to see this family of pediatric eco grow. And now we have, this is our second year running, and all credit goes to our login spokes who have joined from different parts of the country. And we have all prestigious institutes who participate every month. Due to unforeseen circumstances, although it's held on third Tuesday, 2 to 3 p.m., but because we have ongoing World TB Day celebrations going on, so 18th and 19th we could not conduct this session. That was the reason we had to prepone. Sorry for all this inconvenience. Without wasting time, I'll request Dr. Dhulika to take off further proceedings.
Thank you, ma'am. Moving on to today's case presentation. Today's case is being presented by Department of Pediatrics, AIIMS Rishikesh, and the presenter for the case is Dr. Man Singh. He's a DM Fellow in Pediatric Pulmonology and Intensive Care. And the case experts are Dr. Meenu Singh. She's Executive Director, AIIMS Rishikesh, and Dr. Vyas Kumar Rathore, Assistant Professor, Department of Pediatrics, AIIMS Rishikesh. The national expert for today's session is Dr. Sangeeta Sharma. Now I would request Dr. Mansingh to please proceed with his case presentation. Over to you, Dr. Mansingh.
Thank you, ma'am.
Thanks. Your team is there for us.
So,
you get, Doctor.
yes. So this child is a 12 years old child, female, was admitted to us on 10th of January, and she was discharged from 15th of January to this year. She was actually a resident of Darbhanga, Bihar, but they are now residing in just close to us in Haridwar. So she presented with complaints of cough for last 1 month, fever for last 1 month, and blood test sputum for last 3 days. So cough was initially dry, intermittent, but it was progressively increasing from last 1 month, and for last 1 week it has now become productive. And child also had initially had fever, which was mild to moderate grade, and so sometime occasionally with chills and rigor, which they got relieved on oral medication, but fever was low, mild to moderate was persisting for last 1 month. And 3 days prior, to admission. Child had coughing with blood mixed sputum, which was 10 to 15 ml in quantity, and total 3 episodes occur over last 3 days. There was also history of weight loss, but it was not documented, and there was also history of decreased appetite for last 2 to 3 months. There was no history of any pain, abdomen, constipation, any swelling in the body, any seizures, encephalopathy. No history of bleeding from any other side. No history of rashes, joint pain, swelling. No history of any atrophy, environmental trigger. No history of a TB contact, and there was no history of any coughness, shortness of breath, and rapid breathing. The past history was significant. Child in last year in April 24, child had fever and cough for more than 2 weeks duration. For this, child was seen in district hospital where X-ray was done and CBNAT was done. Sputum for CBNAT was in this MTB was detected, but rifampin sensitivity was indeterminate. For this, child was started on first line and ATT on 16th April, but child developed one episode of drug-induced liver injury. For this, ATT was modified for 2 weeks, and after the normalization of liver function, ATT was restarted, and child taken complete ATT for 6 months. And 6 month repeat smear, AB smear was done, which was documented negative, and child was declared cured, and child was at home. And after this, child remain well for 2 months, and then again child is having fever, cough, and 1 month for symptom for last 1 month. Child was completely immunized. BCG score is there. Developmentally is normal. She is study in class 4, is good in study. And in family history, child was first born out of non-consanguineous marriage. There was no history of any TB contact in the family. Birth history was uneventful. So in summary, we have a 12-year girl who is developmentally normal, immunized for age. She has microbially confirmed pulmonary TB. He was diagnosed and treated for 6 months. Child had symptomatic improvement. But now again, child is having cough and fever for last 1 month duration with 3 episodes of hemoptysis and with history of undocumented weight loss. So at this stage, from participant, just I want they can message in the chat box what are the differential they can think, and they can. So we kept possibility of one is because child was already having TB and but just cured out, declared cured, and then even after just after 2 months, child is again having fever, cough, and weight loss. So it may be just reactivation of TB or partial to TB because of this child again is symptom. Though hemoptysis can occur in reactivation of TB also, but it may be because of some post-limit lung disease in. So this is slide on. Another possibility is MDR TB, though we given full drug for 6 months, but the sensitivity of Sibinat was came in previous when the first episode was indeterminate. So we are not sure it was because of low bacillary load or it was because of actual child has resistant TB. So this MDR TB may be one possibility, but though other no other MDR contact was there, child was treated previously well, and Samir was also came negative, and child was also good compliance. This was slight odd point against MDR-TB. Another possibility it may be post-TB lung disease with bronchiectasis, cavity lesion, and because of this involvement of child is having LRTI as well as child because of involvement of bronchial artery may have hemoptysis. And another possibility is just it may be just lower down, which less likely. It may be just simple first episode, maybe simple episode of LRTI because of fever and cough, but duration, hemoptysis, no shortness of breath are against it. One question in chat box is, did you rule out TB contact in his class or school? Uh, uh, in the first episode, I'm not sure, but as per history, in the child class, there was no children have was a symptom, and we have to further we have to discuss with family regarding screening in their school if any child is having other symptom or not. Another question was asked by Dr. Khushbu that was LP was sent from first place of diagnosis. As per as I checked, and as parents were not knowing anything, but they have not any reports. When I check in by the next ID, that only one sample was sent, was CBNAT was came positive. After that, repeat sample was documented as a AB smear that was reported as negative. So when child presented to us, child had heart rate of 42 per minute with a respiratory rate of 24 per minute. White blood pressure was normal. Saturation was 98% on room air. On anthropometry wise, weight was 40 kg, which was between 0 to minus SD. Height was 135 centimeter, and BMI was 21.9. So it was just normal anthropometry. On examination, child was conscious, oriented. There was pallor was there, but there was no icterus, clubbing, and lymphadenopathy. On head to examination, no gross abnormality was detected. On respiratory system examination, there was no in upper respiratory system. There was no deviated nasal septum, no turbinate hypertrophy. Oral cavity in examination, there was no tonsil enlargement. Oral hygiene was good, and ear examination was normal. On lower respiratory system examination, on inspection, bilateral equal expansion was there, no scar mark, Kengo's vein, soul dropping, scoliosis, and there was no subcostal and intercostal retraction. On palpation, there was no tenderness, no localized temperature, trachea was central, bilateral equal expansion were there, and tactile perimeters were equal in all area. In the apex beat was fifth intercostal space in medial line. In percussion, there was impaired note was there in the bilateral infraaxillary and infrascapular area, and the rest of the area was showing resonant note. Liver dullness was in fifth intercostal space with the liver span of 8 centimeter. On auscultation, there was bilateral air entry equal, but it was normal vesical base sound. But in area of bilateral infrascapular infraaxillary area, there are bronchial breathing was there. On rest of the examination, including CNS, CVS, and abdomen examination, were normal. So in database, we have 12-year girl, developmentally normal, immunized for age, now presented with past history of microbially confirmed pulmonary TB, treated for 6 months, now presented with cough, fever of 1 month duration, with 3 episodes of myopsis, and with history of undocumented weight loss, with normal anthropometry, pallor, bilateral capitation with bronchial breathing in infrascapular area. So the differential after this also remains same. Examination, thus we the child he is having bilateral at least lower lobe involvement with area of consolidation. As per examination, as child is having bilateral crepitations as well bronchial breathing in infraaxillary as well in infrascapular area. So this possibility remains the same. Ma'am, it's any comment or question at this stage?
Yes, Dr. Mansingh, do you have the previous X-rays, the X-ray of the first episode when the child received
Yeah.
DSTB treatment?
No, ma'am, we don't have X-ray of that.
And was any culture sent to this patient at that point? IB was not sent, you have mentioned, but was a culture report sent?
So, ma'am, our child was treated at district hospital, and parents don't have, they don't remember. Also, they don't have any reports. In NICS-ID, there were also, and I checked, that was only that one CBNAT and one ABCMR at 6 months post treatment was there.
The CBNAT was also post 6 months.
No, CBNAT was at before starting ATT.
Okay,
And
okay.
but
Okay.
sensitivity was indeterminate, ma'am. MTB
Okay,
was
and
determined, but
okay, and do you have the anthropometry of that time, basically weight at that point of time when the child had received treatment for DSTB?
no, ma'am.
Okay,
I don't have.
okay, okay, okay. You
No,
can
no,
go
reports
ahead.
are not available.
Okay, you can go ahead, please.
So the initial investigation showed with anemia with HbO 9.3, TLC was normal, platelet were okay. Initially, PTINR was deranged 1.88, INR 1.8, but after vitamin K it improved to 1.38, and rest of renal function as well as liver function all were normal. Peripheral smear show normochromic normocytic anemia with the leukocytosis with neutrophilic predominance, and platelets were adequate. This was the initial X-ray when presented to us. It was showing bilateral heterogeneous opacities in mainly predominantly in the right middle as well as left middle zone, as well as some area of consolidation in the upper low right upper as well as the left side also. And right side costophrenic was also not clear. So maybe some mild diffusion is also there on the right side. because child was having active hemopsis, 3 episodes of 10 to 15 ml. So we suspected it may be some bronchial artery aneurysm or from bleeding is there. So we child underwent directly for CT thorax with the CT autogram. So in this, there was right bronchial artery was arising from the descending aorta or at 2 o'clock position, and there was another right bronchial artery which was also arising from the right subclavian artery. It was dilated and tortuous, was measuring 3 mm at origin. And another right inferior phrenic artery was also dilated, and right fourth so eighth intercostal artery is prominent. Usually there are two bronchial left side there were two bronchial arteries happen, and right side there is only one bronchial artery, which usually arise from the right side third intercostal artery. But in this case, or sometime it may be arise from subclavian artery also, or thoracic aorta also. In this case, we have two bronchial ectopic arteries, one arising from the descending thoracic aorta, and one is arising from the subclavian artery. And both were tortuous and dilated. And phrenic artery was also dilated. In the lung part, there was multiple central lobular nodules were seen in bilateral lungs, predominantly in the lateral segment of the left lobe, right upper lobe, and the basal segment of the right lower lobe. And the multiple small cavities with air foci with non-enhancing hyperdense content were also seen in the right lower lobe. And there were right side pleurophusion was there of 6 mm, and the multiple subcentrimetric to enlarged mediastinal nodes are seen, maximum measuring of 9.6 mm in the right upper trachea. So because child was having active hemopsis and bronchial artery were dilated, so we discussed with our intervention radiology team, and then child was taken for bronchial artery embolization. In the during the procedure, they noticed that the right side ectopic bronchial artery was there, which was arising from the right thyrocervical trunk. Right ectopic artery, ectopic bronchial artery was also arising from the descending thoracic aorta, and the right inferior phrenic artery was also or so was dilated and was showing tortuous artery with it was showing with parenchyma blast. So they were selectively embolized with using the 500 to 700 micron of PVA particles. So you can see here that the branch from the right inferior phrenic artery was dilated and tortuous. Similarly, this branch from the right subclavian artery or bronchial artery was also dilated and tortuous. So to rule out the MDR-TB, we again sent sample for sputum for induced sputum for CB0. It was found to have MTB was detected and rifampin resistance was detected. So for this, we have sent LPA and MZ report. Both reports are awaited. Child was started on MDR regimen. They are taking from MDR regimen from referral center from Jolly Grant. And currently child is stable. There was no active hemopsis is there.
Okay, one question, Dr. Mansingh, like what message would you like to give to the house that when should they consider getting a CECT thorax with aortogram in patients who present with hemoptysis for the learning of the house? When should they consider this investigation?
So usually they are mainly bleeding in post TB lung disease usually mainly occur because of damage in the bronchial artery, and so we should do CT autogram. That will be more better within as compared to the CT pulmonary angiography, and we should do when child is having active hemopsis. So any child who is already having history of tuberculosis and now having active hemopsis, it means that some there is problem in the bronchial artery, and we should do citogram and should do by embolization by IR. So if sometimes these children may have massive hemoptysis, and because of this child we can lose these children.
Can I say something on this? Basically, in tuberculosis, it is common to have hemopsis, and in patients who are treated with for tuberculosis, if they are continuing to have hemopsis, so either the disease has not subsided or there are some complications of the disease which have occurred. And many times TB can involve blood vessels, and there can be aneurysms which can develop like mycotic or aneurysms. And sometimes the bleeding is just coming from the surface of bronchial ulcers which may be present. So many times you like to do, if the hemopsis is not massive or large enough, then you do bronchoscopies. and you want to localize what the site of bleeding would be. But in this particular child, when she came back, once she had had a history of being treated for tuberculosis earlier on, and secondly, her hemopsis was larger than what you get otherwise in patients of tuberculosis. It was not massive, but it was very significant hemopsis and was occurring repeatedly. So in this kind of situation, sometimes doing a bronchoscopy may be because the bronchus is obscured because of the blood being present there. It is more pragmatic to go for a CT chest, and with that, one should do a study for angiography, like CT angiography, which can localize the blood vessels. Now, in this particular child, it was very interesting because one could find some anomalies in the bronchial arterial system, and they were tortuous, and they were the ones which were bleeding. So the patient was subjected to embolization. So these are some of the complications which may be there if you do investigations, and you may find them, because sometimes you're not able to locate them and the patient may continue to have problems which may continue. Although in this particular child, there was MTB was detected again with CBNAT, and it was rifampicin resistance. So now the major issue which has happened and which is there for treatment in this child is this drug resistant tuberculosis which has come up. So I think in the subsequent slides, that's what we are going to discuss. So should we continue?
Yes, ma'am. Yes, ma'am. Thank you.
Yeah, please continue.
So this was having drug resistance TB, and so we are not sure it was newly diagnosed in the new case, or it was just all because previous treated and now got acquired TB. And so in the as per in 2023, around 25 lakhs of TB patients were diagnosed, and in India, out of which in 95% were put on treatment, and now success rate is also have improved to 85 to 87%. And drug resistance TB has been reported to up to 3 to 4% in new cases, and while previously treated cases have 18 to 20% have drug resistance TB globally. So in India, around, but problem is that India contribute 27% of MDR TB in the world. So around 1/4 of MDR TB in India, though the number has been reduced from 20% of by 20% from 1.5 lakhs to 1.1 lakh in 2023. And in India, it has been reported that MDR TB cases in new cases were 2.5%, while in the previously treated cases, MDR TB was around 13%. So number of drug resistance cases diagnosed in 2020 were 63,000, out of which 11,750 were pre-XDR and 114 were XDR TB, and 23,000 cases were wholly or monoresistance TB. And treatment success rate in MDR TB has been improved from 49% to 74% in 2024 one, and in the pre-XDR TB also success rate has been improved to 68% in 2021. And as per the longer, when we are in MDR TB, we are giving longer oral regimen, thus there was success rate is around 73%. And so what are various definition which in drug resistance TB? One is the second line drug is the drug that are reserved for the drug resistance TB. MDR TB is the TB which have resistance to both isoniazid and rifampicin, which may or may not have other first line anti-TB drugs. If resistance to both isoniazid and rifampicin is there, it is MDR TB. Monoresistance TB is the resistance to only first line ATT, only one first line ATT drug. Polydrug resistance is the resistance to more than one first line ATT, but this should not include the isoniazid and rifampicin. And the pre-extensively drug resistance TB, it is the resistance to TB, both MDR TB, and that means resistance to both isoniazid and rifampicin, as well as also resistance to fluoroquinolones. And extensively drug resistance TB, that was now redefined it was resistance to both isoniazid and rifampicin, and also resistance to levofloxacin, as well as also resistance to one additional group A drug, that is bedaquiline or linezolid. So these were there were some changes in the definition of this XDR TB. So how to diagnose drug resistant TB? So for drug resistant TB, we can only diagnose by the NTP ensured and quality assured net and culture and drug susceptibility testing, and by using the NTP endorsed testing method in both the public and private center, private laboratories. So if any child who, as per the latest guideline, we have to all children who are suspected to have TB should undergo or universal drugs testing. And uh, if in the seminar, if MTB is detected and rifampin resistance is detected, then treatment will for drug resistance TB, three types of regimen is there. So if children is the more than 14-year, preferred regimen is the BPM regimen, and children is below 14-year. So if child is eligible for shorter regimen, then we can give this. If child is not eligible for the short regimen, then we have to give longer oral regimen. And for mono-resistant, so we can replace with isoniazid with levoflox for around 6 to 9 months duration. So this was latest guideline which came into November 24 for treatment of MDR TB, and these are based on the WHO report of WHO guideline of 2022. In this, now we have for drug resistant TB management, we have three regimen. One is the BPM regimen, another is the shorter oral regimen. BPM regimen is of just 26 to 39 months, 39 weeks, around 6 month duration, while shorter oral regimen is total around 9 to 11 month duration, and the longer oral regimen is from 2019 is around 11 months, 18 to 20 month duration. So in the longer regimen that came in 2018, it have three group A, group B, and group C, and we have to use 5 to 6 ATT from mostly from we have to try to use from group A and group B, and if 5 to 6 drug combination not there, then we can choose from one to two drug from group C. So in group A contain levofloxacin, bedaquiline, and linezolid. Group B contain cycloserine and in group C contain group B contain cycloserine and clofazimine, and group C contain ethambutol, delaminate, pyrazinamide, imipenem, amikacin, ethionamide, and PAS. So you can see that most of the drug which are initially we use injectable now change to oral. So now that is the latest guideline, the preferred regimen in children more than 14 years is we have to give BPM regimen. What is it? I will tell you next slide. It should be given for 26 to 39 weeks. And in children below 14 years, we should try to use shorter oral regimen is the first preference. If shorter is can't be used in below 14 years, then we have to use longer oral regimen. So what is BPN regimen? BPN regimen is just 4 drugs. We have to give for 26 to 39 weeks. There is the B is the bedaquiline, P is the pretomanid, L is for linezolid, M is for moxifloxacin. So it is the first choice of treatment in eligible patient who is more than 14 years with MDR TB. So what are the eligible criteria? First is the person should be age of more than 14 years with newly microbiologically confirmed MDR TB with requiring new course of treatment. And it can, or it may be probable MDR TB who had failed mono or poly drug resistance TB treatment. And but the history of drug exposure should be of less than 1 month duration with bedaquiline, linezolid, and pretomanid. If the duration of exposure of bedaquiline, linezolid, and pretomanid is more than 1 month, then there should be documented sensitivity to there. Otherwise, we can't give this regimen. And because bedaquiline have cardiac issues, because the QT should be documented in 450 millisecond in male and 470 millisecond in the female, and it can also be used in non-lactating women. In lactating women we can use, but they should not be breastfeeding. In pregnant women we can use, but pregnancy less than 24 weeks duration. But they should be valid for parents should be willing for MTP, because this pretomanid have intrauterine fetal effects. So what are the contraindication when we should use, we should not use? If children is below 14 years, if there is documented resistance to bedaquiline, linezolid, and pretomanid, if there is significant liver dysfunction, if there is a severe form of extrapulmonary MDR TB, or if there is having patient is having severe cardiac conduction abnormalities. So you can see that then if there is document to resistance to bedaquiline, linezolid, and predominant. If there is resistance to moxifloxacin is there, we can even use this regimen. So in this, all the 4 drugs are oral. We have to give bedaquiline for first 2 weeks. We have to give 400 mg daily. Then from weeks 3 to 26, we have to give 200 mg 3 times a week. In some cases, if there we have to extend, we can extend up to 39 weeks. But usually this regimen is for 26 weeks. Pretominate we have to give for up to 26 weeks, 200 mg daily. Linezolid we have to give 26 mg, 600 mg once daily, and plus we have to give moxifloxacin from week 1 to 26, 400 mg once daily. So only 4 drugs, 1 to 2 times a day, and only just for around 26 weeks, that around 6 months. So the duration of the longer oral regimen is around 18 to 20 minutes, and we're having 6 drugs. So by this regimen, the duration as well as the amount of the total number of tablets has been also decreased. So next regimen is the shorter oral regimen, which is available, and it is the preferred treatment in children below 14 years, and with total duration is 9 to 11 months. And what are the eligible criteria? One is the child should be have MDR TB, that is the rifampin resistance should be there, and but MDR TB with isolation resistance should be detected. It should be either INHA mutation or KG mutation. If both mutation are there, NHA and KG, then this short regimen we can't use. And MDR-TB with fluoroconistance should not be there. There should be no history of exposure to previous treatment with second-line medicine, and there should be no extensive disease or severe form of extrapulmonary TB. So in children below 14 year, 15 year, we tell is extensive disease we call when there is bilateral cavity disease or there is bilateral extensive parenchymal disease. That is a severe disease. It should not be there. And non-lactating women, non-pregnant women, or pregnant women below 20 to 24 weeks, and that are willing for MTP, in this we can use. But as per latest guideline, that shorter regimen also has been changed. So in previously we were using ethanoamide. So as per latest guideline, ethanoamide can be replaced with 2 month duration of linezolid. If we are using linezolid, we can use this this shorter regimen in pregnant women also. So two types of regimen and short regimen are there. One is the linezolid basis, in which we have to give 2 months of linezolid. In this ethanoamide we can escape. So we have to give 2 months of linezolid with 4 to 6 months of leoflox, clofazimine, pyrazinamide, ethamitol, and high dose of isoniazid with 6 to 9 month duration of bedaquiline. So total duration is around 4 to 6 months with 5 cycle of continuation phase. In this we have to give 4 drug for 5 months. That is levofloxacin, clofazimine, pyrazinamide, ethamitol, and another regimen which is based on ethanoamide, in which we can we use only leoflox, clofazimine, ethanoamide, pyrazinamide, ethamitol, and high dose isoniazid with bedaquiline. So in the pregnant woman, we can use this regimen, pledizolid. In non-pregnant, we can also use this second regimen. Third regimen, which we are already knowing that we are using from 2018. It was having group 3 group, which I already told, group A, group B, and group C. And we have to use we have to try to use almost all the 3 medicine from group A, and at least one or both from the group B. And if we have to use total 5 to 6 drugs, if the total doses are not complete, then we can use 1 to 2 drugs from group C. So longer oral regimen is now indicated. If BPAM or 9 months short oral regimen we can't use, or in this we have to give bedaquiline for 6 to 9 months with along with the leoflox, linezolid, clofazimine, cycloserine, total 18 to 20 minutes. Duration is of bedaquiline is total 6 months, and treatment duration of 15 to 17 months after culture conversion is suggested for most patients. And in children below 5 years, we can either use delaminid or any other class 3 drugs to replace bedaquiline. So these are the drug doses of the various second line drugs. So take home message is that if rifampin sensitivity is indeterminate, then we have to send repeat sample, and we have to ensure proper follow up, so that if rifampin resistance is there, so we have to treat accordingly. If recurrence of symptom is there, then we should suspect MDR TB, And hemoptysis is life-threatening emergency. Urgent intervention is vital. And there are three regimen for oral MDR TB. There is longer, shorter, and BPM. And multidisciplinary team with proper communication with all the team is essential for the successful management. Thank you.
Thank you, Dr. Mansingh. Can you please explain the reasons you started the longer oral regimen in this patient?
Because
Or-
this child was having 15 year and having bilateral extensive pulmonary disease. Because of this, we started on this longer oral regimen, short regimen. Because if severe form of pulmonary disease, we can't use shorter regimen. That's why. And the reports of LPA is still pending, so that's why we started.
So this child was 12 years, I suppose.
Sorry,
I think
12 year. Sorry, she was
okay.
12 year, and there was bilateral extensive parenchymal damage. So
Yes. So with bilateral extensive parenchymal disease, shorter oral regimen cannot be used. Shorter oral regimens can be only used if the child is more than 5 years of age and if there is non-severe TB disease. So because this child had severe TB disease, bilateral involvement was there. So this child was a candidate for all oral longer regimen. So, to summarize, this was a 12-year-old child who had presented with complaints of fever, cough, and multiple episodes of hemoptysis. The child had a previous history of being treated for drug-sensitive TB a few months back. At that time, there was a CBNAT report which had shown MTP was detected, but we are not aware of the mycobacterial load, and rifampicin sensitivity was indeterminate. On the basis of this report, the child was started on DSTB regimen, and after a few months, he presented again with cough, fever, and hemoptysis, along with weight loss and a loss of appetite. For hemoptysis, when he was worked up, there were abnormalities that were found, and he was bronchial artery embolization was done, and CBNAT report revealed that mycobacterium was detected and resistance was also detected. And in view of bilateral extensive disease, this child was started on all oral longer regimen. Over to you, ma'am, for your comments on this case, Dr. Sangeeta.
I think Dr. Meenu, would you like to add something regarding the management? Dr. Meenu Singh? Very interesting case your department has, your institute has presented. So, any comments from your side, Dr. Meenu?
Very important that we all learn about treating drug-resistant tuberculosis. We all in the pediatrics group. Because
Ma'am, I think you're on mute.
Can you hear me now?
Yes, ma'am.
Yes,
ma'am.
yeah.
Okay, so I think it's very important that we all pediatricians learn how to treat drug-resistant tuberculosis now. And we see it with increasing frequency in this age group, especially girls, that is beyond 14, 13, 14 years of age. And various regimens are now available, and these three patients have to be monitored very closely. So, all the centers which are offering DOTS Plus and who are drug resistant TB treatment designated centers, they have to follow these patients. But I think we should also continue to follow these patients because otherwise, sometimes there is a break in the treatment because treatments are still long, although shorter regimens are available, but they are only for less severe forms of disease. So I quite think that this child also we'll have to follow very closely, not only for her tuberculosis, but also for her vascular malformations that she had, for which she needed uh, procedure, for embolization of the bronchial artery. So these are some of the things. I think the key message is treatment with newer regimens and a very close follow-up for the drug-resistant TB patients in children.
Thank you, ma'am. Dr. Sangeeta, ma'am, would you like to add something to this?
I think you can, are there any questions in the chat box?
Or
any raised hands? Anybody wants to ask any question?
So, Dr. Khushbu wants to know that how would we define bilateral extensive disease if suppose a patient with CF may also present with pulmonary TB who may have lung damage due to underlying disease. So, how would we define bilateral extensive disease in such patients?
Ma'am, it was in the guideline. It has documented that it was that if there is bilateral in children, if there is bilateral cavity disease, and also bilateral extensive damage, it was not clearly defined how much involvement is there. But this I will show. I have slide.
What is it now? What is the question?
The extensive damage, extensive disease.
हाँ उसमें दिया तो था आपने. You are have you shared these slides with them?
Yes. So it was defined as presence of bilateral cavity disease or extensive parenchymal damage in the chest radiography. And in children, it was defined as in under 5-15 year, if there is presence of cavity or bilateral disease on chest radiography. That is a severe form of TB. For extrapulmonary in the children, anyone except for pleural effusion or lymphadenopathy, all are severe extrapulmonary TB.
Anything, Dr. Meenu, you want to add regarding the lung involvement in children?
Yeah, lung involvement in children can be extensive, it can be minimal, or it can be, like we used to classify it. In many of these patients where we are getting extensive involvement of lungs, there we are also trying to investigate them for MSMD, which is Mendelian susceptibility to mycobacterial disease, which is a form of immune deficiency in which about 10 variants are known. And we have occasionally found that these patients are interferon gamma, they do not express interferon gamma or IL-10 genes, which are essential for fighting tuberculosis. And sometimes it starts as a drug sensitive tuberculosis, but since the immunity is not geared up to deal with this bacteria, the bacteria do tend to become resistant. And then we have to treat drug resistant tuberculosis. And many times the disease is present in the rest of the family members also. So it becomes extremely important also to check on other family members in the patient, which we should do. And for extensiveness of tuberculosis, I don't know if we can do anything else because this disease will heal by, fibrosis, or sometimes there can be lung destruction. There can also be development of bronchiectasis and some complications over bronchiectasis. We have seen patients who may develop aspergillus colonization and go on to develop ABPA if their TB is treated and they have bronchiectasis, which is TB related. So these are some of the complications and these are some of the consequences of extensive disease, which all happens in miliary tuberculosis because sometimes they start with miliary TB and they have tuberculosis in other organs as well besides lungs. And sometimes it does become difficult to treat these patients, but because as you know, drug resistant TB is quite difficult to treat even with the availability of new drugs. Although earlier beta-glucan containing regimens were not available for children less than 6 years of age, but they were there for older children. But now with the availability of these regimens and also the shorter regimens, I think one should treat these patients with all the available therapies which are there.
So, yeah, so I would just like to add over here, what Dr. Meenu has said regarding the severity of lung involvement. WHO has defined some criteria, especially for children. I mean, if sputum is positive, culture is positive, CB-NAT can be positive, but smear and culture positivity, they go in favor of more severe disease. then involvement of not more than 1/3 of one lobe of lung. Then if there are presence of cavities, then it is also a severe disease. And if there are hilar lymph nodes which are causing compression, or there is complicated pleural effusion, they are also criteria for labeling as severe disease. So these criteria, and obviously miliary, as Dr. Meenu has said. So any involvement more than 1/3 of the lobe of the lung, be it unilateral, be it obviously bilateral, and as in this case, this was bilateral lung disease. So automatically it goes to the patient shifts to a severe form of pulmonary tuberculosis. Although, other criteria like microbiologically based, we do not know about the sputum smear status. Neither do we know about the culture status right from the beginning part. So only CB-NAT was positive. So if only CB-NAT is positive, then it can be non-severe disease. And if less than 1/3 of the lung is involved, the unilateral, without any, as I said, the lymph node, hilar lymph node should not be causing any compression. If there is pleural effusion, it should not be complicated. And if there are peripheral lymph nodes only, that is non-severe. Rest all extrapulmonary in children are severe forms of disease. So I think any more questions you would like to ask? Yes.
Dr. Mansingh, I just want to know, okay, what are the status of fluoroquinolone regarding the first or second line LP of this patient was sent, and what are the status basically in this patient?
report नहीं आई
Yes,
ना
sir.
अभी
Yes, sir. LP has been sent, sir. Report is awaited.
Reported.
Awaited.
Thank you.
So any more questions?
Sir, ma'am, this BPM regimen is now available, or
Yes, BPAL-M has been implemented throughout the country. The age criteria, and also that is more than 14 years, and we are giving BPAL-M. 6 to 9 months of BPAL-M. Moxiflox is given irrespective of resistance to fluoroquinolones. So, because there are plenty of studies which say that presence of moxifloxacin, despite the case being pre-XDR, has a benefit in prevention of emergence of resistance to bidacillin. That is the reason we are giving moxiflox in that regimen. One is the age criteria more than 14, and you have also discussed all the criteria regarding where to give the shorter 6 to 9 months BPAL-M.
Dr. Jayakishan has a question or a
Yes, sir.
So the topic given was the stitch in time saves the nine. Okay. So here what I want to comment that in case of the child where the CB-NAT was positive, okay, so we should be actively looking for the say first line and the second line LP reports. 1, 2, we should be looking for this culture report. 3, 2, and in case the culture get contaminated, and in that also, so we should be repeating this sample, and the treating physicians also, and the IR lab where the culture is being done, they should be actively asking for the sample again for say picking up the MDR TB or drug-resistant TB at the earliest. Okay, and then the hemopsis is not uncommon in case of these adults also, and in case of the children also. And besides the cases which are discussed causes, there may be endobronchial TB, there may be bigger focus, there may be the erosion of the blood vessels by the lymph nodes, especially in the primary TB. And there may be one of the most common is the bronchopulmonary osmosis. So here in this case, we had gone for the CT angiography. Okay. So at worst stage, this is not uncommon. The CT angiography is not available at many of the centers. So in the opinion of the experts, when we should be asking for the CT angiography? Should it be for each and every case for the stitch in time, save the 9 case, or particularly we should be ordering this investigation in which scenario?
I would like to answer this question. It should be done, CT angiography should be done in cases of hemopsis when they are massive or they are recurrent or they are significantly large. Because in TB, the hemopsis is there many times, but usually it is blood mixed with sputum and it's not like a massive hemopsis. But if there is a hemopsis which is likely to lead to one blockage of the bronchial tree because of the blood itself can come up and block the bronchial tree, and secondly, if it can exsanguinate the patient or patient can actually land up in shock and hemorrhagic complications. So in those emergency situations, actually, with along with CT, angiography should also be done to locate, because there may be malformations as was seen in this case, and sometimes there may be mycotic aneurysms which develop in these blood vessels because of infection, because TB is going on, and because of that there may be involvement of the blood vessels. So those are the indications. Like, they are not done in all other cases of TB where hemopsis is minimal.
So in case the blood vessel is eroded by the enlarging lymph node, or in case of the endobronchial tuberculosis, whether the CT angiography will be able to pick at the early stage.
So it can pick up if it is significant, because the leak from the blood vessel can also be can be picked up in angiography, and sometimes you need to do a bronchoscopy. Many times we pick up these lesions on bronchoscopy if there is a lymph node which is bursting into the tracheobronchial tree, and that starts bleeding. That also leads to bleeding, because many times that bleeding is not very massive. They are usually mixed with the secretions which come out with the caseous secretions, and blood is mixed with them.
So for the academic purpose,
So,
how
sir,
to
in those cases, if there is a bronchus which is bleeding on bronchoscopy and there is a lesion, in those cases we may have to use local laser or local techniques to stop the bleeding.
So whether the vigor focus will also be picked?
Which focus, sir? I missed the question. What was the question? Can you repeat, the moderator? सर मैंने आपका क्वेश्चन मिस कर दिया. Last part of the question.
I think
Hello? Whether the vigor focus, the focus of the tuberculosis in the vessels can also be picked by the CT angiography?
Sir, usually you don't see focus of tuberculosis inside the blood vessels, because
But rarely
they
it can be, na?
rarely it can be. If there is a mycotic aneurysm which has developed, then it certainly gets picked up. But we haven't actually seen other lesions like obstructive lesions or granulomatous lesions which might be involving the blood vessels, which can happen, like when it leads to, say, large vessel involvement, and there are obstructive changes. For example, Takayasu, initially people used to think that tuberculosis is the agent which leads to this problem. So there one can think of larger vessels being involved with because of the tuberculosis infection. So larger lesions, yes, sir, they can be picked up with angiography.
Thank you.
Thank you, sir.
Dr. Mansingh, there is a question regarding the protocol for children with IDDM and MDR-TB. Would you like to answer?
MDR-TB
and IDDM, insulin-dependent diabetes mellitus.
Oh, that doesn't change anything. It's the same regimen.
Same.
The diabetes has to be controlled with insulin, and tuberculosis has to be treated like all other regimens which have been given for TB.
I would now like to call upon Dr.
I would like just one comment to add over here for diabetes. Most important is to control the blood sugar, by if it is insulin dependent, give insulin. But otherwise, if it is non-insulin dependent, bedaquiline and the drugs, metformin, etc., anti-diabetics, they're all safe to use with the bedaquiline. I just wanted to add this.
Yeah.
Yeah.
But in children, you mostly have insulin dependent
Yeah,
diabetes.
yeah.
I would now like to invite Dr. Sangeeta Sharma for her summation remarks. Over to you.
So, we have had this very interesting case in which the diagnosis was um, most important thing is that when do we go on to the second line drugs? Next. So, if there is non-response or there is adverse drug effects to the first line drugs, that is also rarely. Next. But in this case, now we need to understand that what is the usual response to ATT. Whenever we start ATT in a child, in this child, I would like to say that initially, the sample, there is only CBNAT report which is available. But the flow of samples in children, as is with adults, is that two samples they have to be collected. Sputum, that is one is spot, and the other is, if it is the second spot, that is after 1 hour, or it is morning and spot. And these two samples, the first sample goes to the NAT site, and the second sample automatically goes further to the lab which is doing liquid culture. And the first thing that the intermediate reference lab, they do the smear, and depending upon the result of the smear, if it is positive, then they go on to the first line then they go on to the LPA first line, and if need be, second line in cases of MDR TB and or INH resistant TB, and automatically the sample goes for the liquid culture. So this was probably missed in this case. So for information of the house, whenever we have to send a sample, because in children or the samples they're very precious, try to, if it is sputum, then we can have two sputum smears. But if it is a gastric aspirate, it's a single sample, and then automatically this, rather than sending to the NAT site, it goes to the intermediate reference lab, and they will do everything. So now, with this background, probably the child, although it was RIF sensitive, RIF indeterminate, the sample should have been repeated because it was sputum sample. And also the status of the liquid culture, the first and second line LPA, they were missed in that time. But ATT was started. Now let's go further on, the usual response on ATT. So we assess any child on clinical, radiological, and bacteriological parameters. Usually, the child starts to improve, when we start ATT by 2 to 4 weeks. The fever starts to come down, the cough, takes a bit longer to improve, but weight gain, it usually starts within the first 4 weeks. Uh, there are nearly 25% children who do not show any significant weight gain. But it is in totality, if you see your child is improving as per when the ATT was started, you can say that there is some clinical improvement. Now, coming to the radiological improvement, the lesions, as we all know, radiological lesions, they take much longer, to show signs of resolve. And the bacteriological conversion, it usually occurs within the first 2 months of start.
Is it audible? That our facilities in
Sorry.
district hospitals, for diagnosis and treatment of tuberculosis are not adequate.
Yeah.
Because many times, one is that availability of CBNAT is also a problem there. And secondly, once they are like, in this particular patient, they was being treated in the district hospital. And there, if they get indeterminate CBNAT, they don't have facilities to go to, the intermediate labs, and that network of labs needs to be strengthened so that patients don't get missed. For example,
Exactly.
this patient did get missed, and we get lots of patients from UP, from Saharanpur, Muzaffarnagar. These are the areas where there is hardly anything which is there in the districts, and the patients have either been started on treatment, but then they don't follow up in the dot centers. So I think that area is something which also needs to be strengthened, and I think we must inform the program of respective states that these areas actually need strengthening.
Yeah, Dr. Meenu, a point very, very valid, All the facilities, they are available under the program. But I think it is even, I would say, apathy of the treating clinician, Because whenever they see a child, they feel, oh, iska to sputum positive hoga hi nahi. So, that kind of attitude also needs to change. And we over here, pediatricians, we need to spread this message that the government those facilities are available, but sample collection and sample flow, it is the duty of the treating physician to ensure, that all this is done. Uh, uh, I feel even the program needs strengthening, but I think it is we all of us we are answerable, being the treating clinicians. So, going further, now regarding the response, if there are any of these three scenarios, the red, that is persistence, or if there's recurrence of the symptoms, or there is a delayed response, all these next. Many so all these, they need to make us suspicious that there is something which needs, the clinical radiological microbiological delay or deterioration, or there is non-response. So it needs to make the clinician suspicious. Next. So the questions which we need to ask is it TB, non-TB? And if it is TB, then is it true non-response or recurrence or or into which the clinical plus radiological or plus microbiological non-response is occurring. And, depending upon if it is clinical and radiological, then it is a presumptive DRTB and we need to send the microbiological investigations. And if there is microbiological deterioration also, that truly defines a true non-response. Now, in cases of clinical radiological deterioration, samples need to be sent because that will decide whether the child is got microbiologically confirmed or clinically diagnosed. That is probable MDR-TB. Next. And obviously, if it is microbiologically confirmed, then we need to have the DST at hand. Next. And obviously, site of disease. Next. Severity, as we have already discussed, because severity will guide us to which regimen has to be given. Next. And if there is any comorbidity, that is, any superadded infection is there, or there is diabetes, HIV. Next. And any past history of ATT, and even any history of contact in the household, if there has been a death in the family, if there is a DRTB, MDR-TB a patient in the family, or there is an adult who is taking chronic irregular treatment, all these, should make one suspicious that it could be a case of DRTB. Next. So, these are, I would say, whenever there is a usual causes of poor or non-response, first and foremost is that we need to always keep in mind that whether our diagnosis was, whether it was not wrong diagnosis, but in this case, the diagnosis was not wrong. It was not a case of clinically diagnosed TB. The child had TB because the CBNAT showed MTB detected, although RIF resistance was indeterminate. And also we have to check about the DST reports, that whether they are from a accredited lab. please, this is very, very important. We need to see this, that the report which is in front of us, whether that is, from a accredited lab. And then also keep in mind MOT, because smear positivity continuing. In case the CP-NAT is negative, it could be a pointer that either, the child has MOT. Then obviously confounders, and the other thing is post-lung TB disease. If you've completed the treatment, there could be a superheaded infection which is causing a poor response, and presence of comorbidities, that is diabetes, HIV, etc. Then also wrong treatment. Like in this case, we had discussion regarding the treatment regimen to be given. Obviously, the age of the child is 12 years, so the child is not eligible for BPA-LEM. uh, Two regimens are left. That is the shorter regimen. Shorter regimen we could not give. Reason being because there was bilateral involvement. So the criteria, the wrong regimen, then the wrong doses, because doses are also very important. I have seen prescriptions where the drug dosages, they are not given. For children, the dosages are milligram per kilogram body weight. And utmost important is next, poor compliance. But also keep in mind DRTB and paradoxical response. This is when the child is on treatment, because paradoxical response is when the immunity of the body improves. That is the time. This is a scenario which is seen in HIV positives and even for HIV negatives. TB, only TB patients. That is when the immunity improves, then the body starts to, the lesions, they may increase, the child may start to have fever. But the only distinguishing point feature is that you need to rule out drug resistance by sending the samples to differentiate between the two. Next. So we have already discussed this. Next. So appropriate sample which is available needs to be sent for all these investigations, that is NAT, and the second sample or the precious sample automatically goes to the intermediate reference lab where they do a smear. They do, depending upon the smear, if it is positive, first line, second line LPA. If it is negative, they put it on MGIT, and then it is an indirect LPA for the drug sensitivity along with the phenotypic DST, that is the culture based DST. Also, always send HIV and blood sugar. Next. Now there could be scenario, if it is determined that is the DST shows drug sensitive tuberculosis, then you have to restart DSTB treatment. Next. But if it is shows there is poor response to drug sensitive treatment, it could be presumptive DRTB, then you have to resend the samples because it could have been missed. Next. And if the results show DRTB, then you start the DRTB regimen as per the DRTB algorithm. Next. But then there are circumstances or scenarios where you are unable to get hold of the DST DRTB. In these scenarios, most important is if there is a family contact, then take into consideration the DSTB, DST of the family or the household contact, because that is important. And also keep in mind next that it could mean be non-TB, or it could be a paradoxical upgrade response. Next. Or probable MDR. If you have ruled out everything and you're sure about the diagnosis, that the diagnosis is tuberculosis, but you are unable to fish up the organism, then is the diagnosis of probable DRTB. And this diagnosis is based on you have to take the help of the DRTB committee with all the records of the patient, and then they decide the best possible regimen. Next. So differential diagnosis, if the bacteriological confirmation is not achieved, is always keep in mind that whether it is TB, it may not be TB. Then you have to review your diagnosis. We have seen so many cases. In fact, I had a case who was referred to me that this is a MDR lymph node TB. So I just, asked the dadi of the child that any other complaint to the child. Dadi said कि इसको दौरे भी पड़ते हैं. It just clicked to my mind कि it could be, the child is on phenytoin. So she put that dibby of phenytoin on my table. So, immediately, although to come to the diagnosis, we had to send all the relevant investigation, that is FNAC, etc. We also got the phenytoin blood levels done from AIMS Delhi. So it turned out to be phenytoin toxicity. So always, you need to review your diagnosis. We have seen cases of lymphoma. We have seen other cases also more if AFB smear is coming positive. Then paradoxical upgrading response I've already discussed. The only differential is that the reports will tell you whether it is PER or it is MDR. Next. So, to sum up, it is that whenever there is a child on ATT, there is poor response and there is no comorbidity, or the child is on ATT for more than 1 month and is lost to follow up, that means there is a gap of TB drugs of more than 1 month. So then we have to send all repeat investigations. And in this case, like the child was cured on ATT, but then he had reappearance of symptoms, fever, cough, etc. So it could be reactivation, and we need to send the samples again. So I think this is all what I wanted to say regarding the diagnostic part of this child. And any questions? Dr. Meenu, would you like to add something over here? Okay. So, over to Dr. Dhulika.
So with this, we come to the end of the 11th Pediatric TB Eco Clinic, and it was a very fruitful discussion that we had today. The next TB Eco Clinic is scheduled for 15th of April, and the presenting team is PGI Chandigarh. But before we sign off, I would like to invite Dr. Sangeeta Sharma again for her closing remarks.
So this is on behalf of our Dr. Ashok Bhardwaj, because he is the National Task Force Chairman. Because of the ongoing World TB Day celebrations that are going to be held from tomorrow, 18th and 19th, he could not join because he was busy in another meeting. So on his behalf, he told me that I need to give the closing remarks. I think this was a very interesting case where, we need to spread the knowledge. And Dr. Meenu had very rightly selected this case that, right from the beginning, if we are particular about the sample collection and the sample flow and transportation, there are things, which can be better managed. So with this, I would like to end today's session. And thank you all for joining, and see you again next month. As Dr. Dhulika has said, the next team would be PGI Chandigarh. So the schedule will be the same. I think we don't have any other celebrations coming. So it would be the third Tuesday, 2 to 3 p.m. So see you all, and thanks all for joining. Thank you all.
Thank you. Thank you.
Thank you all.